Hello students and welcome in my online session. I am Professor Manoj Garar. Let's begin today's session on next cardiovascular disorder, that is arrhythmia and anti-arrhythmic drugs. This is important area to understand because sometime question will be asked on class of drug, activity and side effects. I will guide you through the key points. The word arrhythmia means alteration or irregular heart or simply abnormality in heart rhythm. Heart rhythm. Before looking deep into the arrhythmia, firstly we will see how heart muscle contract in presence of electric impulse. So this slide show you the normal contractile function of atria and ventricles evaluated by ECG. So ECG nothing but electrocardiography is the process producing the electrocardiogram, recording the heart electric activity. So ECG consists of electrocardiogram and that having different waves like P, Q, R, S and T waves and represent the different function. So starting with P waves. So these P waves indicate atrial depolarization initiated due to the SA node, and here is the interval between the P and Q represent the atrial depolarization completes. After that QRS wave arises. So this QRS indicate the ventricular depolarization begun and atrial repolarization occurs. So here ST interval indicates the ventricular depolarization is completes. So after that T wave arises that indicate the ventricular repolarization begin, and finally there is the one straight line indicate the ventricular repolarization is complete. So this picture show you the normal activity in atria and ventricles, that is the depolarization and repolarization is recorded through the electrocardiograms and we can check the normal activity. So any abnormality in that activity they can directly represented through that waves. Okay, next we are going to discuss, that is what is cardiac action potential. So normally for the activity of the heart there must be generation of impulse, and this impulse conducted through the conducting system for the contraction of ventricle or finally pumping of blood. So heart consists of myocardial cell. So myocardial cell surrounded by the lipoprotein membrane, and that membrane having the different ion channel. That ion channel or pump maintain the different concentration gradients of different ions. So for example, in extracellular fluid there is the higher amount of sodium ions, and inside the myocardial cell there is the more amount of potassium ions, and this different concentration gradient is maintained by one pump, that is the sodium potassium ATPase pump. So these are the play important role to maintain the different concentration gradients. So what happen when the impulse is generated in SA nodes? So we can say AC node also known as the pacemaker. Normally inside the myocardial cell remain negative, that is minus 90 millivolts, in comparison to its outside compartment. The transmembrane potential in SA node remain minus 70 millivolts during the polarization state, while it remain minus 90 millivolts in non-spacemaker cells. So transmembrane potential for SA node is minus 70 millivolts, and for non-spacemaker cell or conducting cell, uh, like AV node, Purkinje fibers that have the transmembrane potential near about minus 90 millivolts. So this is the difference in spacemaker and non-spacemaker cell. So actually in spacemaker cell, how the action potential changes and impulse generate. Look at this graph, how the potential changes from negative to the positive and again restored to the negative. Consider this graph for the spacemaker cells. What happened in spacemaker cells? So spacemaker cell does not have the true resting potential as like the spacemaker cell. As like the non-spacemaker cell, they have the resting potential near about the minus 90 millivolts, but in case of spacemaker cell, they does not have any true resting potential. So the voltage start about the minus 60 millivolts and spontaneously upward until it reaches to the minus 40 millivolts. At that threshold potential, or at the minus 40 millivolts, funny channels opens and allows slow influx of sodium, resulting in depolarization at a 40 millivolts. Funny channels opens and slow influx of sodium ions result in the depolarization, also known as the spacemaker potential. At the threshold, calcium channel open and calcium flow into the cell, further depolarization. That phase called as rising phase, depolarization or rising phase, also known as the action potential. At the peak of that potential, the potassium channels open, calcium channel inactivate, and potassium ion leave from the cell, and voltage returns to the minus 60 millivolts. So due to the potassium channel open, potassium ion leave from cell and graph returns to the minus 60 millivolts. So that phase called as falling phase or repolarization. So original ionic gradient are restored to several ionic pump and cycle start over. So this is the spacemaker action potential. Now action potential in non-spacemaker cell or myocytes or conducting tissue. So this diagram represent the what will be change in potential, also shows the what type of moment in different ion during this space, during this process. So this diagram indicate the there are the different phases and depolarization, repolarization. Now when SA node gives the impulse or produce the impulse, that impulse spread through the conducting system toward the contractile myocytes, and that contractile cell have the different ions channels. So contractile cell have the stable resting potential near about the minus 90 millivolts. When the cell is depolarized, myocytes is depolarized, the stimulant usually by the neighboring myocytes. When the stimulant come from the neighboring myocyte, the myocytes is depolarized. So at that situation, in myocyte there is the more sodium and calcium inside the cell. These positive ions, these sodium and calcium ions, leak one myocytes to the another adjusting myocytes and bring the membrane potential this cell up to the threshold potential, that is approximately the 70 millivolts. When the one myocyte leak the positive ion to the adjacent myocytes, there is the change in potential and achieve the minus 70 millivolt threshold potential. In myocytes, their minus 70 millivolt is a threshold potential. At that, fast sodium channels open and create a rapid sodium influx and sharp rise in voltage. This depolarizing phase or phase 0, that is the spike action potential. Phase 0 occurs due to the fast opening of sodium channels and influx of sodium ions. At the same situation, L type or slow calcium channel also open at 40 millivolts and causing slow but steady influx of calcium ions. So calcium ions also enter in the inside the myocytes and sodium ions. Uh, as potential near to its peak, sodium channel close quickly and voltage gated potassium channel open, and this result in small decrease in potential. So this phase known as the partial repolarization, or you can say phase 1. At phase 2 or plateau phase, the calcium channel however remain open and potassium efflux is eventually balanced by calcium influx, and this keeping the membrane potential relatively stable for about 200 milliseconds, result in plateau phase. So membrane potential keep stable due to the balancing of balance of potassium ion efflux by the influx of calcium ions. After that, at that situation, whatever the influx of the calcium ion is not enough to induce the contraction, so instead of it, it trigger the release of stored calcium ion from the sarcoplasmic reticulum. So that process known as the calcium induced calcium release for the contraction of cardiac cell. So at phase 3, as a calcium channel slowly close and potassium efflux predominantly, or increase the potassium efflux at the phase 3, and voltage returns to its resting value. The calcium is actively transported out of cell and also back to the sarcoplasmic reticulum. So thus at the end of the repolarization phase 3, the transmembrane potential is restored back again to the 90 millivolts, but now intracellular fluid has a lots of loss of potassium ion and gain of sodium ions. So here sodium potassium ATPase pump again play role by utilizing ATP to actively transport the sodium out of cell and potassium into the cell to restore the normal level of that ion. So this process occurs sequentially, that is the depolarization, partial repolarization, plateau phase, and repolarization again restore the potential and also to restore the normal level of sodium outside the cell and normal level of potassium inside the cell. So these diagram represent the hot type of the moments occur in particular phase moments of ion. So consider the phase 0, there is the inward movement of sodium ion. Phase 1, there is a outward movement of potassium ion. Phase 2 indicate the balancing of efflux of the potassium ion by calcium ion and relatively stable the potential for the 200 millisecond, and phase 3 represent the outward movement of potassium ion. So these process mainly occurs only in non-pacemaker cell, that is the conducting tissue, AV node, Purkinje fiber, bundle of His for the contraction of ventricles. Now next, uh, looking toward the uh, abnormality or cardiac arrhythmia. So cardiac arrhythmia is an abnormality in rate, rhythm, site of origin, the conduction of cardiac impulse. Okay, so in simple language, so arrhythmia or normal action potential is near about the 100 to 110 beats per minute. So this is the normal action potential. And normal sinus sinus rhythm is near about the 60 to 100 beat per minute. So this is the normal action potential and normal sinus rhythm. So what's mean by sinus rhythm? So sinus rhythm nothing but the impulse generated in SA node, then it is conducted in bundles of fish through the bundles of fish and Purkinje fiber through the AV nodes, and contraction is occur. So this one cycle is nothing but the single. So AC node release the impulse, and that excitation of the heart tissue take place in the ordinary manner by spreading the impulse throughout the specialized automatic fibers in the atria, resulting contraction of atria. AV node function as the delay circuit and conduct this impulse slowly down bundles of fish to the Purkinje fiber and ventricles. So these process nothing but the sinus rhythm. So in 1 minute, 60 to 100 sinus rhythm occurs. This is the normal. In case of abnormality, if sinus rhythm below the 60 beats, the abnormality known as bradyarrhythmia. And if rhythm or sinus rhythm occurs greater than 100 beats per minute, the abnormality known as tachyarrhythmia. Next, so what are the mechanism they can arise the arrhythmia? So there are the four mechanism through the arrhythmia arises or occur: re-entry, automaticity, parasystole, trigger activity. So one by one we can discuss. meaning of that mechanism and how they can produce arrhythmia. Now first, that is the re-entry required. So normal sequence of electric impulse conduction, that is electrical impulse started in SA node and conducted in bundles of his Purkinje fiber through the AV nodes and reach at the ventricle. So this is the normal unidirectional flow. So what happened in case of re-entry? The conducting system is large enough so that conduction pathway are repolarized before next sinus impulse arrive at AV junction. So this bundle of his Purkinje fiber ventricles, these are the repolarized before next sinus impulse arrive at AV nodes. So this is the normally. In case of re-entry, what happened? Due to the development of premature arterial impulse or due to the complete block of conduct, conduction, the impulse after causing a ventricle's contraction, they travels toward the atria, and that direction, we can say this is the retrograded direction. If sequential direction, that is the antigraded direction, or after the contraction of the ventricles impulse travel toward the atria, that direction nothing but the retrograded direction. And that due to the retrograded direction of that impulse, that can leads to the re-entry of circuits and or produce the loop like structure. So this diagram represent the re-entry occurs due to the unidirectional block in one, those pathway are slow conduction in the unblocked pathway. So next mechanism, that is automaticity. Other than SA node like AV Purkinje fiber sometimes also act as a spacemaker and generate the self impulses. So that impulses cause the automaticity or ectotic arterial tachycardia. So due to the that spacemaker, there is the again due to the impulse generation from other than SA node, there is the abnormal rhythm occurs. So factors enhancing the automaticity include the level of carbon dioxide, level of the oxygen, increase the level of hydrogen, and stretch, hypokalemia, hypocalcemia. So these are the factors they can induce the automaticity in other non-spacemaker cell. So that can leads to the ectopic atrial tachycardia. Next mechanism, they can cause the arrhythmia, that is the benign types of automaticity problem that affect only the small region of atrial or ventricular cell. And last is triggered activity. Now what are the classification of arrhythmia? So depending on the location, we can classify the arrhythmia into the different category. So main two heading, that is a supraventricular arrhythmia, means abnormality in atria, and second one, that is the ventricular arrhythmia, means abnormal heartbeat in ventricles. So first, that is a supraventricular arrhythmia, that having the different types, that is the sinus bradycardia if heart rate less than 60 beats per minute. Sinus tachycardia means heart rate greater than 100 beats per minute. Paroxysmal supraventricular tachycardia, so rate in between 140 to 250 beats per minute. So atrial flutter or atrial fibrillation, this severity of an increased automaticity enhance from the tachycardia to the flutter and then fibrillation. So firstly tachycardia, and that leads to the flutter or fibrillation. So atrial flutter characterized by the rapid atrial firing at a rate to 240 to 400 beats per minute. In atrial fibrillation is characterized by rapid or disorganized atrial rhythm at rate 350 to 600 per minute occur due to the random or changing the firing of that automaticity. So next, Wolf Parkinson White syndrome and premature atrial characteristics. So these are the types of supraventricular arrhythmia. So here this diagram represent the different parts of that hertz and where the that arrhythmia actually occurs. The next ventricular arrhythmia. So having three types, that is the premature ventricular contraction, ventricular tachycardia, then ventricular fibrillation or ventricular flutters. So in case of ventricular flutters, again heart rate in between 150 to 300 per minutes. Due to that we can see this is the atrial flutter. And in case of atrial fibrillation, so heart rate from 150 to 500 per minute. So heart rate is rapidly increases or random fashion from the ectotic foci present. So next, looking toward the main point of our discussion, that is the anti-arrhythmic. Now coming toward the next anti-arrhythmic agents. If you understand the normal cardiac action potential graph and their different phases, that is depolarization and repolarization. So what are the different ion channels? They are play important role to generate the depolarization and repolarization phase. So then you will understand the classification of antiarrhythmic agents. So look the cardiac action potential. Look at this this diagram. This diagram indicate the different phases and different ion channel responsible to generate the phase. Suppose here the sodium channels responsible to generate the phase 0. Here the potassium channels responsible to generate the phase 1. Here the calcium channels responsible to generate the phase 2, and again phase 3 is generated due to the potassium channels. So we can directly target these channels and normalize the heart rates. So depending on that phase or channels, we can classify the antiarrhythmic agent. So first class, that is the sodium channel blocker. Second class, that is the uh, beta blockers. Third class, that is the potassium channel blocker, they act at the phase 3. And fourth class, that is the calcium channel blockers, they mainly target the phase 2. So looking the classification, chemical classification of that antiarrhythmic agent given by Vaughan William classification. So there are the four main types of the classification. So class first and their subclass, that is the class 1A. So that is the moderate sodium channel blockers. So that subclass, that is the class 1A, block the sodium channels at a open state, also block the potassium channels and cause the prolongation of QT intervals. Class 1A drug, by blocking the sodium channels, decrease the phase 0 depolarization. So what are the example of class 1A drugs? So first, that is the quinidine, second procainamide and disopyramides. So we can remember these three drugs by applying the simple short, that is the question produce the difficulty. So question, nothing but the quinidine, procainamide and dyspyramides. So next subclass of class 1, so class 1b, that is the mild block sodium channels. So they can block the sodium channels in inactive state and possess the potassium channel opening properties. Remember these points. So these class 1b, they can having property to open the potassium channels, so that they might decrease in the phase 0 depolarization and also decrease in the ventricular automaticity. So what are the examples of that class 1b? That is the lidocaine, mexiletine, also phenytoin, also example of class 1b. Next subclass, that is the class 1c. This is the marked block the sodium channels. So they does not have the property or effect on the potassium channels, they only block the sodium channels. So we can say this is the marked decrease in the phase depolarization and prolong the QRS intervals. So what are the example of these class drug? That is the flecainides and propaphenols. These are the example of class 1c. So next class of the antiarrhythmic drug, that is the class 2nd, beta blockers, block the adrenergic beta receptor, decrease in the heart rate, AV conduction and ventricular automaticity. So example, you know that the propranolol, acetylol, esmolol, sotalol, these are the beta blockers. Then class 3rd, or you can say this is the potassium channel blockers. They can block the potassium channels, and due to the potassium channel, or they can act on the phase 3 of the cardiac action potential and prolong the ventricular repolarization. Phase 3 prolong the QT intervals. So what are the example of these class third antiarrhythmic agent? That is the amiodarone, dofetilides, ibutilides, sotalol. These are the example of class potassium channel blockers. And last, class 4, that is the calcium channel blocker. They mainly act on the phase 2 of that action potential and decrease the heart rate, AV conduction, increase the PR intervals by blocking the calcium channels. So example only diltiazem and verapamil. So we know that the calcium channels, there are the two types of calcium channel blocker, that is the dihydropyridine derivative, but that dihydropyridine derivative does not shows the antiarrhythmic activity. Only diltiazem and verapamil shows the antiarrhythmic activity. So remember notes, that is some drug have the both class action. For example, so class 1 agent also have the class 3rd property, or propranolol also have the class 1 action, or in case sotalol and beryllium have the both class 2nd and class 3rd action. So remember these points. Depending on the type of arrhythmia, we can prescribe the particular antiarrhythmic agent. So for the supraventricular arrhythmia, we can prescribe only the verapamil and diltiazem. For the ventricular arrhythmia, we can prescribe the lignocaine, mexiletine, beryllium. Or for the both supraventricular ventricular arrhythmia, amiodarone, beta blocker and disperamide, these are the only for use for the both supraventricular and ventricular arrhythmia. Next slide indicate the target of different class of drug. They can target the different phase in action potential. So next, now we will understand the chemistry of individual class and individual drug one by one. So firstly, uh, class first, membrane depression drug, subclass, that is the class 1A. So example, quinidine, procainamide and uh, disperamide. So these are the example of class 1A. So look one by one. So first drug that is quinidine, and this quinidine first antiarrhythmic agent use treat the both atrial and ventricular arrhythmia, increase the refractory periods. So firstly use as an antiarrhythmic agent. So quinidine found in cinchona bars, and these are the diastereomer of quinine. So quinine, this is the anti-malarial, and the diastereomer of that quinine, that is the quinidine. If look at the structure of quinidine, they have the two types of ring, that is the quinoline ring and bicyclic quinoclidine rings. So these both ring are bridge or joined by the hydroxymethylene bridge, that is the hydroxymethylene bridge. So this is the chemically quinidine contain two types of ring, and that ring also have the heterocyclic heteroatom, that is the nitrogen. So due to that two nitrogen, this shows the basic property. So due to the basicity of that quinidine, they it always use water soluble salt, that is the sulfate and gluconate. If sulfate derivative, sulfate salt, they are having the 95 absorption property orally, and uh, if the quinidine in gluconate salt, they given intravenously respectively, use the higher viability or absorption. So these quinidine metabolized in liver through the orthodemethylation to hydroxylate derivative of the quinidine ring. So at the quinidine ring, there is the orthodemethylation occurs, that is the metabolites formation, or in case of quinoclidine ring, at a vinyl group there is the oxidation occurs. So this is the metabolites of that quinidine. Next action of quinidine. So quinidine mainly blocks the myocardial sodium channels at an open state, and reduce the automaticity or maximal rate of phase 0 depolarization is reduced, and frequency dependent manners. It also blocks the calcium channel, leads to the prolong the QT interval and increase the action potential duration. So this is the action of quinidines. Then next drugs of class 1A, that is procanides, and is mainly trade name, that is the pronistil. This is the benzamide derivative. Benzamide derivative. So it increase the refractory period. It can be effective in patients who are unresponsive to the quinidine. Those patients are unresponsive to the quinidine, then we can use the procainamide. It was developed from the local anesthetic, that is the procaine. It is the ester bioester. Procaine is the ester bioester. By replacing the ester by the amide bioester, there is the development of procainamide. So structurally, if look at this procainamide, it contain diethyl aminoethyl, benzamides, and para amino group. So this is the structure of procainamides. We can say this is the benzamide derivative. So look at these structures. So IUPAC name of this structure, that is the para amino N 2 diethyl aminoethyl benzamides. It had the little antiarrhythmic effects because has a CNS side effects, and has developed the drug induced lupus syndrome, that is the side effect. Increase the antibodies, that is the side effect of procainamides. Because amide, it is more stable in the water, so that procainamide shows the oral active properties and has the 80% viability. Metabolized by the N-acetyl procainamide, or metabolism of the procainamide is N-acetyl procainamides. So next, they also act by the blocking the sodium channels. The next drug of the class 1A, that is the Dyspyramides. Dyspyramide is a oral intravenous antiarrhythmic medication used in treatment of ventricular tachycardia. So structurally, dyspyramide, these are the acetamide derivative. Acetamide derivative. If look at the structure of the acetamide dyspyramide, so acetamide at the alpha carbon there is the substitution, that is the phenyl substitution, pyridine substitution, isopropyl diisopropyl amino ethyl substitution at the alpha carbon of acetamide. So this is the simple structure. So the IUPAC name of this pyramid is alpha 2 diisopropylamino ethyl alpha phenyl pyridine acetamides. So this is the, simply remember the acetamide derivative. It is the sodium channel blocker, therefore the classified as the class 1A antiarrhythmic agents. These pyramids has the negative inotropic effects on the ventricular myocardium and significantly decrease the contractility. Peak plasma level of that dyspyramide within the 2 hours. They achieve the peak plasma level. For the achieving the peak plasma level, they require the 2 hours, and half life of that dyspyramide near about the 6.7 hours. N-dealkylated metabolized form. So side effect like dry mouth, constipation and urinary irritation. Second subclass, class 1B, they can block the sodium channel in inactive state and possess the potassium channel opening properties, so they can prolong the QT intervals. So drug of this class, for example, lidocaine, mixilidine, phenytoin and tocanides comes under the class 1B. They can mild block the sodium channels and possess the potassium channel opening properties. So talking about the first lidocaine drugs, so it was introduced as a local anesthetics and laterally it is used intravenously for ventricular arrhythmia if amiodarone is not available or contraindicated. It short it shorter the action potential duration and refractoriness. It is a drug choice for emergency treatment of ventricular arrhythmia. When talking about the structure of lidocaine, as we know, lidocaine is the amide derivative, belong to amino-amide class of local anesthetics. So chemically it consists of mainly acetoxylidine ring or moiety. So acetoxylidine nothing but xylene, as we know, the 1,3-dimethyl benzene, this is the xylene, and when acetanides simply without the methyl substitution, this is the acetanilide. So acetanilide and xylidine to form acetoxylidine. So at this carbon here is the diethyl amino substitution. So we can write the IUPAC name for lidocaine, that is a 2-diethyl amino 2,6 acetoxylidine. So structural important functional group to shows the pharmacological action. So it must be contain the aromatic ring. So this aromatic ring enhance the lipid solubility. So then amide linkage that can provide a stability to enzymatic degradation as compared to the ester, and terminal amine group allowed lidocaine to uh, interact with sodium channels in its charge form. So this is the structurally important functional group to show the antiarrhythmic activity. So next, parentally lidocaine has the 70% plasma protein bound and half-life is 30 minutes. Hepatic metabolism involves the N-deethylation and yield monoethyl glycine xylidine. So this is the metabolites of lidocaine. Question will be asked on the metabolites of lidocaine. So remember the metabolites of lidocaine, that is monoethyl glycine xylidine, and shows the antiarrhythmic activity. So this this is overall about the lidocaine. Then next, what are the side effects of lidocaine? CNS effect, dizziness, paresthesia, epileptic seizures. So these are the side effect of lidocaine. Remember this. Next drug in class 1b, that is lidocaine. Sorry, tokenides. So alpha methyl analog of structurally related to the monoethyl glycine xylidine. So this is the metabolites lidocaines, and structurally related analog, that is tokenides. So here we can see the structure of tokenides. So tokenides, again, these are the derivative of acetoxylidine. Acetoxylidine. But at this carbon there is the methyl substitution and amino substitution only. So we can simply write the tokenides. As pharmacological active, every sodium channel blockers that structure found it contain amide groups. So this is amide group is essential for the activity. So next, drugs of the class 1b, that is mexilitine, and these mexilitine sold under the trade name, that is the Mexitil, is a drug used to treat the abnormal heart rhythm. And structurally, so this mexilitine is the xylaloxy derivative. So when tokenide and lidocaine, which contain acetoxylidine, instead of acetoxylidine, mexilitine contain the xylene as well as phenoxy. So we can say this is the xyloxy. Remember the word xyloxy. From the xyloxy you can remember the mexilitine. At this carbon there is the methyl and amino substitution like the tokenides. So only structural difference in the tokenide and mexilitine, that is ether linkage, and in case of tokenide there is a amide linkage. So next, common side effects of this mexilitine include abdominal pain, chest discomfort, drowsiness, headache, nausea. It work as a non-selective voltage gated sodium channel blocker. Belong to class 1b. Like tokenide, mexilitine have very good oral activity, absorption property, and it mainly metabolized by the CYP2D6, and it has a relative long plasma half-life near about the 16 hours. So next drug of class 1b, phenytoin. So for the 50-year, phenytoin has seen as an anticonvulsant that also work as a antiarrhythmic similar to the lidocaines. So for 50 years, phenytoin has seen as the anticonvulsants. and they also shows the antiarrhythmic activity. So structurally, phenytoin, these are the 2,4-imidazolidine dione derivative. So this is the 2,4-imidazolidine. So 2,4-imidazolidine dione derivative at the fifth carbon of that imidazolidine dione, there is the diphenyl substitution. So we can write the IUPAC name for the phenytoin, that is the 5,5 diphenyl 2,4-imidazolidine dione. Structurally, this is the analog of barbiturates but does not possess their extensive sedative properties. As like barbiturates, phenytoin does not show the extensive sedative properties. Available in the sodium salt for the parenteral administration, 40% propylene glycol and 10% alcohols. It is discovered when the toxicity of it observed in the patient being tested for the seizure disorders. During the testing of phenytoin for the seizure disorder, so phenytoin discovered as the antiarrhythmic drug. It can be administered either orally or IV. Peak plasma level achieved after the 12 hours. So for the phenytoin to show the pharmacological action require the 12 hours. For IV injection, it must be dissolved in the highly alkaline vehicles. So this is about the phenytoins work as a antiarrhythmic agents. So next class, next subclass, that is class 1C, most potent sodium channel blocker, or we can say this is the markedly decrease the phase 0 depolarization, no effects on repolarization and action potential duration, because subclass of 1C drug, they does not shows the any effect on the potassium channels, they only affect or only block the sodium channels. This agent can only use in ventricular arrhythmia. So there are the different example of class 1C. For example, lorcainide, propafenone, these are the example of class 1C. Flecainides and morizicin also example of class 1C. So starting with the lorcainides, that is the first class 1C drug, lorcainides. So lorcainides structurally, it is the member of acetamides, and when looking to the structure of the lorcainide, that contain the chlorophenyl, then acetamides and piperidine substitution, also there is the phenyl substitution. Okay, so mainly remember the core structure, that is the acetamides. On that acetamide there is the either a substitution on the carbon or on substitution on nitrogen. So here this is the nitrogen, on the nitrogen there is the substitution, or carbon there is substitution. So the core structure is the acetamides. And structurally, lorcainides that must have the aromatic ring. So aromatic ring or phenyl contribute to its lipophilicity and interact with the sodium channels. Due to the aromatic ring in lorcainides, they can interact with the sodium channels. So that is the aromatic rings. And in case next essential functional group, that is the amide group. Lorcainide contain the amide functional group, which critical for its pharmacological activity. So this is amide group is essential for the to show the pharmacological action. Then side chain methoxy group attached to the aromatic ring of that secondary amine group in its alkyl side chains. So they are also essential for the activity. So lorcainides is the class 1 C antiarrhythmic agent and helpful to restore the normal rhythm and conduction in the patient with premature ventricular contraction or ventricular tachycardia. Only in case of premature ventricular contraction we can use the lorcainides. So next drug, flecainides, class 1 C drug. uh, Structurally flecainides have the benzamide core structure, benzamide core structures. Okay, on that benzamides aromatic ring also substituted, and on nitrogen there is also substitution. On the aromatic ring here there is the 2,5 substitution, that is trifluoroethoxy substitution, trifluoroethoxy substitution. And on that nitrogen there is the 2-piperidonyl methyl substitution. So this is the 2-piperidonyl methyl substitution. So remember flecainide also the benzamide derivative. Then flecainides is the fluorinated benzamide derivative available as a acetate salt. Clinically study suggests that this agent can be more effective than the either quinidine dispyramide in suppress the premature ventricular uh, contraction. So these are the more effective than the quinidine and dispyramides. So oral flecainides is well absorbed and plasma half life is approximately the 40 hours. Plasma half life, that is the 40 hours. Half of the flecainides is metabolized by the CYP2D6 in liver and undergoes biotransformation forming the meta or to dealkylated compound whose property are half as a potent as those of the parent drugs. So biotransformation occurs in case of flecainides and forming the meta ortho dealkylated compounds. So next, morginides. These also comes under the class 1C drug, and chemically these morginides are the morpholine propionyl compounds, morphonyl propionyl compound. So we can say this is the phenothiazine derivative, phenothiazine derivative. So treatment of malignant ventricular arrhythmia, we can use the morgicin. Short half-life after the administration, oral administration, due to the CYP1A2 metabolize, its antiarrhythmic effect can be persist for the many hours due to the metabolites of that morgicin. And class 1C antiarrhythmic agent block the sodium channels with 1:1 stoichiometry. The drug has a higher affinity for the inactive state than the active state or resting state of that sodium channels. It has been used to suppress the life-threatening ventricular arrhythmia. So these are the some properties of morgicin, and these morgicin are orally active because of that their metabolites. So next, propafenones. So again, propafenones, these are the next class 1C antiarrhythmic drug, that is the propafenone. Chemically that propafenone, these are the 3-phenyl propionephenone derivative. 3-phenyl propionine derivative. So as all of you know, the structure of acetophenone. So acetophenone, also known as the benzophenone. So like that class, the benzophenone, here the 3-phenyl propionine core structure. So this core ring present in the propionine. So this propionine is developed by substitution at a second position of that 3-phenyl propionine. So at this substitution second position, there is a 2 hydroxy propyl amino propoxy substitution at the third position. So formation of propionine. So structurally, remember the 3-phenyl propionine at the second position, there is the 2-hydroxy propyl amino propoxy substitution. So this is the class C anti-arrhythmic drugs, and they can block the uh, sodium channels as well as also shows the beta blocker activity. So next our class of the anti-arrhythmic agent, that is the class second, beta blockers. So based on the two major action, blockade the myocardial beta adrenergic receptor and direct membrane stabilizing effect related to the sodium channel blockades. So remember the one point. So these beta blockers, they can shows the antiarrhythmic activity by depressing the calcium influx through inhibition of the beta receptors. So this is the main action of the beta blockers. They can directly depress or decrease the calcium influx. So example, sotalol, propranolol, esmololol. So these are the beta blockers. All of you know. So next, chemistry of the propranolol. So first drug of the beta blocker, that is the propranolol, and all of you know this propranolol are propanolamine derivative, and it is developed from the dichloroisoprenaline by inserting the linkage, that is the methoxy linkage. Okay, so chemically this propranolol are the propane to OL. These are the core structure. On that propane to OL, there is the substitution. So consider this is the first carbon and this is the third carbon. Okay, so at that carbon there is a substitution. So on that first carbon, here is the substitution of isopropylamine, and on that third carbon there is the naphthaloxy substitution. So naphthalene 1-yl oxy substitution. So this is the chemistry of the propranolol. You can simply write the chemical IUPAC name of the propranolol as we discuss in the antiarrhythmic agent, and they can block the beta blockers and shows the antihypertensive as well as the antiarrhythmic property. So next drugs of the beta blocker, that is the sotalol. So chemistry of that sotalol, it is an ethanolamine derivative. It is an ethanolamine derivative. So ethanolamine, nothing but this part, ethanolamine derivative. So it is an N-phenyl methane sulfonamides. It is an N-phenyl methane sulfonamide, and on that N-phenyl methane sulfonamide at a fourth number carbon or fourth position, here is the substitution of 1-hydroxy 2 isopropyl amino ethyl. This is the substitution at the fourth position of phenyl methane sulfonamide. So chemistry of that sotalol, and these again shows the antiarrhythmic activity by blocking the beta blockers. Also sotalol shows the class third antiarrhythmic property, because they can also block potassium channels. Okay, so next class of antiarrhythmic drug, that is class third antiarrhythmic drug or potassium channel blockers, so also known as the repolarization prolongators, repolarization prolongation or prolongators. So that beta blocker mainly act on the potassium channel and block the potassium channel and develop because the patient patient negative patient negatively sensitive to the sodium channel blockers. That's why potassium channels are developed and cause that potassium channel causes the delay in the repolarization and prolong the refractory periods. So class third drug cause the homogeneous prolongation of duration of action potential. So this is the main action of potassium channel blocker. They can increase or prolong the duration of action potential, and this result in the prolongation of the effective refractory periods, and that finally gives the normalize the whatever the heart rate increase or whatever the heartbeat is increased, they can normalize by the potassium channel blockers. It believed that most of the class third antiarrhythmic agent act through the phase 3 of the action potential by blocking the potassium channel. So these drugs mainly act on the phase 3 of the action potential, that is the repolarization phase. So example of the class third antiarrhythmic agent like beryllium, amiodarone, ibutylide, dofetilide, azimilide. So these are the example of potassium channel blocker, or we can say this is the class third antiarrhythmic agent. So one by one we can discuss the chemistry of that potassium channel blockers. So first drug, that is the beryllium tosylate. So chemistry of that beryllium tosylate, the first developed to treat the hypertension but found to also suppress the ventricular fibrillation associated with myocardial infarction. So it was firstly developed as antihypertensive and laterally developed as the ventricular fibrillation associated disorder. They can suppress the ventricular fibrillation so that they can act as the anti-arrhythmic agents. Okay, so chemically these beryllium are the bromobenzyl quaternary ammonium compound, bromobenzyl quaternary ammonium compound. So this is the chemical derivative of that beryllium. So quaternary ammonium salt derivative, and when writing the IUPAC name of this compound, we can write the orthobromobenzyl ethyl diethyl ammonium tocylin sulfonates. So these are the IUPAC name of that compound, toluene sulfonate. Then beryllium is used only in intensive care units and can administer either intravenously, intramuscularly, only administered to the intramuscular or intravenously, and it is only used in the intensive care units. So half life of that beryllium tosylate near about the 10 hours. So next drug of the class third antiarrhythmic, main drug of beta potassium channel blockers, that is the amiodarone. So amiodarone it is prolong the action potential, prolong the action potential, prolong the action potential by delaying the potassium efflux, but many other effect characterized by the other classes. It is approved by the FDA for treatment of life threatening ventricular arrhythmia that are refractory to the other drugs. So FDA approved for the treating the life threatening ventricular arrhythmia firstly. So amiodarone is the main drug of potassium channel blockers, and chemically these amiodarones are benzofuran derivative, benzofuran derivative. Chemically amiodarone is a benzofuran derivative. On that benzofuran there is the substitution at third position and second position. So here is the substitution, that is the second position substitution, and this is the third position substitution. So at the third position there is a substitution of for 2 ethyl amino 2 ethyl amino ethoxy 2 ethyl amino ethoxy 3,5 diiodo. Here is the iodo group, 3,5 diiodo benzoyl group, benzoyl group. So this is the at the third position of the benzofuran there is the substitution of diethylamino ethoxy diiodo benzoyl substitution, and at the second position of the benzofuran there is the substitution of butyl group. At the second carbon of that benzofuran there is the butyl substitution. At the third carbon there is the substitution of the diethylamino ethoxy diiodo benzoyl substitution. So this is the chemistry of amiodarone. We can write the IUPAC name of amiodarone like 2 butyl 3 benzofuran 4 2 diethylamino ethoxy 3,5 diiodo ketones. So act as a class 1, class 2nd and class 4th antiarrhythmic properties. They can also show the other class property like class 1st they also block the sodium channel, class 2nd beta blocker also act as a beta blocker and also act as a calcium channel blockers. Its severe toxicity however make it is the drug of the last choice amiodarone. Because of the severe toxicity of the amiodarone, these make the last choice of the drug for the treat the ventricular arrhythmia or antiarrhythmic arrhythmia caused due to the different mechanisms. So amiodarone mainly is eliminated very slowly from the body with the half life near about the 25 to 30 days. So remember the one points, that is half life of amiodarone is near about the 25 days after the oral administration. 25 days for the shows the half life of the amiodarone required the 25 days. Next drug of class 3rd antiarrhythmic sotalolol. As we know the chemistry of the sotalolol, that sotalolol also act as the class 3rd antiarrhythmic, also act as the beta blockers, that is the class 2nd antiarrhythmics. So there is no need to explain the sotalolol in the class 3rd. So next last class of the antiarrhythmic agent, that is calcium channel blockers. So as we know the calcium channel blocker having the different drug, so we can chemically classify the calcium channel blocker into the two category, that is the dihydropyridine, that is the one major class of the calcium channel blockers, and second one class of that calcium channel blocker, that is phenylalkyl amine, phenylalkyl amine. So these are the two main chemical class of the calcium channel blocker. So when talking about the antiarrhythmic activity, so antiarrhythmic activity only shown by the phenylalkylamine derivative. So the dihydropyridine derivative does not have the antiarrhythmic activity, they only act as the anti-anginal drug, antiarrhythmic agent. So remember these points, so that so when writing the drug of calcium channel blocker as an antiarrhythmic, only two drugs come for the to treat the arrhythmia, that is the diltiazem and verapamil. So they can show the antiarrhythmic property by slowing the rate of AV conduction in the patient with atrial fibrillation. So this is the near a little about the calcium channel blocker act as a antiarrhythmic drug. So next individual drug of the calcium channel blockers. So first that is verapamils. So when talking about the verapamil chemistry, so they can block the sodium channels, in the addition to the sodium channel also block the AC node in the tachycardia and shows the antiarrhythmic property. So what is the chemistry of that verapamils? So verapamils, they are the tertiary amino compounds. Tertiary amino compounds also contain the polyethers. So this is the polyaromatic ethers. So you can say polyaromatic ether or aromatic ethers, and also contain the nitrile functional groups. So these are the component or functional group of that are present in the verapamil structure. So chemically, these verapamil are the phenyl alkyl amine derivative. These are the phenyl alkyl amine derivative. So this is the phenyl alkyl amine derivative, and which contain the different aromatic ether functional group. Also contain the tertiary ammonium compound. So this is the tertiary ammonium compound. Tertiary ammonium compound and nitrile functional groups. So they can show the they can block the calcium channels as well as sodium channels and shows the antiarrhythmic property. So next drug of the antiarrhythmic calcium channel blockers, diltiazem. Diltiazem. So chemistry of the diltiazem. The nucleus of the diltiazem is 4-oxo 2,3,4,5 tetrahydro 1,5 benzothiazepines. So this is the core structure or nucleus of diltiazem. So which contain benzothiazepine nucleus or ring, that is the benzothiazepines. At the benzothiazepines, here is the substitution at second carbon, third carbon, fourth carbon also substituted by the oxo group, and fifth position there is the nitrogen. So here remember the second, third carbon is substituted by different group, and fifth number also, fifth position also substituted, that is the ends also substituted by the different groups. So mainly at the fourth number carbon there is the oxo, so that we can write the 4-oxo 2,3,4,5 tetrahydro 1,5 benzothiazepines, and at second position there is a substitution of 4 methyl phenyl ring, 4 methoxy phenyl rings. At third position there is the acetate substitution, 3-vial acetate substitution, and at the fifth position there is a substitution of the dimethylamine ethyl. So dimethyl ethyl amine ethyl substitution at the fifth position of the diltiazem. So this is the chemistry of diltiazem. Again, this diltiazem act through the blocking the calcium channels and shows the antiarrhythmic properties. Okay, so here we can cover the all the individual drugs of antiarrhythmic agents and their basic knowledge about the what are the mechanical causes of that arrhythmia, how they cause, and what is the normal function of the heart through the cardiac action potential. So thank you very much.